those things. So probably now what we'll be talking about is what Madam also started the discussion was with or without diabetes. So now I'll be talking about some of the case scenarios where semaglutide has been used in the management of people with diabetes, and I've been fortunate enough by God's grace to be a part of some of these trials with semaglutide, the injectable ones, the focus trial which is looking currently undergoing also for the efficacy of its or the safety parameters of its worsening of retinopathy, and probably a couple of more GLP, Cagricima and other things. Thank you, Magna Code Foundation, for giving me this opportunity. And I think we didn't hear any of the snoring, so I think everyone is alert. And thank you, Dr. Santosh, for setting up the stage about the importance of the weight, its impact on the cardiovascular diseases, and how to tackle about the weight, some of those things. So probably now what we'll be talking about is what Madam also started the discussion was with or without diabetes. So now I'll be talking about some of the case scenarios where semaglutide has been used in the management of people with diabetes, and I've been fortunate enough by God's grace to be a part of some of these trials with semaglutide, the injectable ones, the focus trial which is looking currently undergoing also for the efficacy of its or the safety parameters of its worsening of retinopathy, and probably a couple of more GLP, Cagricima and other things. So a couple of my experiences also I'll be sharing. So hold on to your seat and sit tight. There we go. So we'll be talking about the benefits of early multifactorial therapy in reducing the risk of complications in type 2 diabetes, the role of GLP-1 RAs in targeting multiple pathophysiological defects of type 2 diabetes, the oral sema, the new standards which it has set in the management of type 2 diabetes, and benefits beyond the glycemic control. So now, a newly diagnosed type 2 diabetes, 33-year-old lady who was obese, BMI of 29.5 kilogram per meter square with an A1C of 8.5%, comes with high cholesterol, dyslipidemia, who is on metformin 1000 milligram twice daily, mostly maximum tolerated dose, sedentary lifestyle. Mother had family history of, she has got a very strong family history of type 2 diabetes, died at the age of 65 years with CVD. Patient concerns are increasing HbA1c level with increasing weight and the associated comorbidities. So we have to understand that this has been again, time and again, by the follow-up data of H.No 2 trial has been told that early multifactorial therapy reduces the risk of complications in people with type 2 diabetes. So we have to target the H.No 2 targeted glycemic control, the platelet inhibition, aspirin, dyslipidemia control, the blood pressure lowering, and the lifestyle modifications, including the weight management. So the intensive and the whole of this trial period ran for 7.8 years, very small group, 160 in each group, 160 patients, they followed up. So the follow-up after 21 years of follow-up, with 7.8 years of initial intensive management led on to a decrease in the all-cause mortality of 45%, survival of more than 7.9 years in the intensive group, and time to first CVD event of 8 years, and the microvascular complications, relative risk reduction decreasing to the tune of 48% also. So we also understand that higher HbA1c predicts the higher CV risk. The fatal and the non-fatal MI, if you see that 1% reduction in the HbA1c reduces 21% relative risk reduction for any endpoint related to diabetes, 21% for death related to diabetes, 14% for myocardial infarction, and 13% relative risk reduction for microvascular complications. So, greater weight loss improves obesity-related complications. We understand that less than 5% of weight loss leads on to some improvements in the hypertension and hyperglycemia parameters. 5 to 10% of weight loss, prevention of type 2 diabetes, NAFL, PCOS, and some parameters of dyslipidemia. 10 to 15% leads on to some improvements in the cardiovascular disease outcomes, urinary stress incontinences, OSA, GERDs, NASH, what Dr. Santosh did focus upon, knee osteoarthritis, definitely. And then more than 15%, again, a direct implication of direct trial leads on to more number of patients with type 2 diabetes remission, lesser incidences of heart failure with HFpEF and CV mortality. So HbA1c is still reducing at more than 15% weight loss. So more the weight loss in the obese segment or in the people with obesity, HbA1c gives a better value there. So early intensification prevents the long-term complications. So a legacy effect which we did speak of is a long-term benefit conferred to individuals who have been having controlled sugar in the very early stage of the diabetes. So 1% of HbA1c reduction immediately after diagnosis leads on to 20% of risk reduction for myocardial infarction, 90% risk reduction for all-cause mortality, delaying 1% A1C reduction until 10 years after the diagnosis leads on to a very dismal number of 7% risk reduction for MI and 3% relative risk reduction for all-cause mortality. So this gets on to the importance of early control of diabetes. So early initiation of newly diagnosed patients to avoid complications and mortality. So that leads on to the very important aspect of a clinical practice, which is your legacy effect or the metabolic memory, which probably we have to understand and pass on to the patients, telling that the initial phases of the diabetes journey is what really matters for the longer term control. So GLP-1 receptor agonists target multiple pathophysiological defects of type 2 diabetes. GLP-1 is an endogenous molecule. It's an incretin hormone secreted in the gut in response to the food intake. Yeah. So when you take food, there's increase in the blood glucose level along with certain of the amino acids also are potent signals for the GLP-1 secretion that lead on to increased levels of insulin secretion, decreased glucagon secretion, decreased glucagon production, decreased gastric emptying, improving the satiety and decreasing the food intake, improving the beneficial effects on the cardiovascular system, and with a very low risk of hypoglycemia. So then coming about the pioneer trials, there have been n number of pioneer trials, the numbers ranging from 1 to 12, Pioneer Plus, Pioneer Real, and whatnot. So most of the data has been quite a good number of elaborate data in various subset of the patient population has been done. So what it talks, the Pioneer one had semaglutide versus placebo in newly diagnosed patients of diabetes who are treatment naive. So in them, so the achievement of composite target of an A1C of less than 6.5% plus a weight loss of more than 5% was better with oral semaglutide versus as compared to that of placebo. If you see, it ranges from 20% in oral sema versus placebo of 8.5%, and then over the follow-up also within less than 1 year and more than 1 year also, oral sema did achieve a good composite target there. Oral semaglutide has showed superior A1C reduction versus DPP-4 inhibitor, that is again Pioneer 2 trial design. It showed that versus sitagliptin as an active comparator had better A1C reduction with oral semaglutide 14 milligram as compared to that of sitagliptin. So oral sema also showed superior A1C reduction versus SGLT2 inhibitor. That's again Pioneer 2, which was studied in some 800 plus patients, showed better A1C reduction versus SGLT2 as an active comparator. Yeah. So then oral semaglutide showed better weight loss in the trial settings as compared to that of the SGLT2 inhibitors in that of the Pioneer 2 trial design, which we had already discussed. So if you see this bar diagram, what we understand is that higher proportion of patients achieve better targets with oral semaglutide compared to other active comparators, be it in monotherapy, be it versus EMPA versus ITA, even versus liraglutide, and with insulin added upon to insulin also gives you a better number of patients achieving good control of diabetes, the target A1C levels. So GLP-1 receptor agonists reduce body weight through appetite suppression. So energy intake and food consumption overall are reduced with semaglutide versus that of placebo. So if you see the energy intake during ad libidem lunch time, so in someone who is on semaglutide, they did consume roughly around 2,300 kilojoules versus placebo of almost 3,600 kilojoules of energy. So there's a 35% relative risk in the difference energy intake on sema versus not on oral sema. So sema versus placebo, they had the patients on sema did score better on the questions related to food cravings and control eating and portion sizes, while still feeling meals were still pleasant. So overall, some calculated model gives us a rough estimate that people on oral semaglutide tend to lose a 4.7 centimeter of waist circumference. So the clinical attributes of concern or of importance for oral semaglutide includes here superior A1C reduction versus EMPA and sitagliptin, and clinically relevant weight loss through appetite suppression, providing the efficacy of GLP-1 RA in an oral formulation, and providing significant waist circumference reduction. So now going to the second case scenario, who is again a patient with a type 2 diabetes with multiple cardiovascular risk factors. So this is a 47-year-old male, BMI of 30 kg per meter square, A1C 9% with hypertension, dyslipidemia, currently on metformin, DPP-4 inhibitor and SGLT2 inhibitors. The patient concerns are, as usual, the worsening HbA1c levels, worsening weight, comorbidities, and family history of CVD. So GLP-1 RA in this clinical context of increased cardiovascular risk factors has beneficial effects on the multiple beneficial effects on the cardiovascular system. Potential mechanisms of the beneficial actions of GLP-1 in the cardiovascular system include your improved endothelial function, improved vasodilatation, clot stability, better blood flow, and improving the diuresis and natriuresis, decreasing the inflammation, smooth muscle proliferation, and platelet aggregation, leading on to its supposed cardiovascular benefits. So Pioneer 6, this was the cardiovascular outcome trial, the CVOT trial done for oral sema, which showed a 21% non-significant relative risk reduction in the MACE events, and there were lesser amount events in the oral semaglutide group. But we need to understand that this was done for non-inferiority. The trial for again superiority is awaited, I think. So oral sema demonstrated a favorable CV profile, which you can see that it was non-inferior to placebo in terms of MACE, and the cardiovascular death was statistically significant to the tune of relative risk reduction of 51%, and the all-cause mortality was also better to the tune of 49% of RRR reduction with oral semaglutide. So oral semaglutide also reduces the systolic blood pressure by 5 millimeters of mercury. So hypertension does increase this cardiovascular risk in people with diabetes. So we understand that a 5 millimeter decrease in the systolic blood pressure translates to decreased relative risk reduction or of 13% in stroke, 7% for IHDs, 14% for heart failure, and 5% for deaths related to diabetes. And then it also reduces the LDL and triglycerides. So LDL cholesterol and triglycerides level are better with people on oral sema versus that of the placebos. So oral semaglutide also reduces the vascular inflammation. So CRP in couple of these trials showed that it was better control or lower in people on oral semaglutide. So choosing the right antidiabetic agent, so we understand the pros and cons of various antidiabetic agents. Now we have got an armamentarium of the oral antidiabetic agents, including insulin, the injectable ones, including the injectable GLP-1s also. But if you see again, one of the potent molecules are these GLP-1 receptor agonists for your glycemic control, with a very good effect on the body weight, with cardiovascular risk reduction, with multiple pleiotropic benefits, with a very low risk of hypoglycemia. So probably GLP-1 receptor agonists do play a good important role in ticking on all of this. So I think with this I'll end the talk. Any questions, or we can directly wind up, whatever the organizers feel. Nausea, GI side effects are very common. The nausea is mostly the predominant one. Usually Indians tolerate to pretty good extent 3 milligram and 7 milligram. Escalating from 7 to 14 is usually an issue in Indian patients. Yes, ma'am. Except this DPP-4, because DPP-4 is also acting on the same incretin mechanisms, so it wouldn't add any of the value if you combine a GLP-1 with a DPP-4. Yes, ma'am. Yes. Yeah, if you ask me lifelong, but most of the Indian patients, I don't think they'll be able to take it up that. But my discussion goes with initial starting up this therapy for 6 months, 3 months, make them see the results of that and probably then see how things go on. So a couple of my patients are 6 months through after seeing the good weight loss benefits. So I think they are wanting to continue. So probably next year also I might come back and tell if any of my patients did continue more than a year also. Thank you. So I think.
Thank you, Basaraj.
Thank you.